we're going to talk about SIMV now. So that's the third mode of ventilation from the obsolete modes of ventilation that principles of vent. So the set parameters here: tidal volume, respiratory rate, FiO2 and PEEP, and pressure support. That means it's the third type of breath here, right? And the dependent parameters are tons. We have peak inspiratory pressure, plateau pressure, respiratory rate, and also anything that has mandatory and spontaneous before it. So spontaneous tidal volume, mandatory is tidal volume. Spontaneous minute ventilation, mandatory is respiratory rate, respiratory. So basically, there is a lot that tells you that what happened here. Obviously, there is a spontaneous and mandatory component to your breathing, and not only that, the vents advancement. In the 90s, started with advanced enough that we now have feedback from the patient. Before that, we didn't have any feedback from the patient, right? And feedback from the patient is very, very important because once you see what's happening inside the patient, you can actually make some adjustment and stuff like that. We didn't have that capability before. In the 90s, we had some. So basically, between the 70s and 90s, there was a lot of modes of ventilation that were developed. Between 1970 all the way to 1990s, one of them is called IMV, and one of them is called, it was some time cycled modes which were similar to bi-level, but the vents were kind of sticky and the valves are not working and all of these things, so it didn't work out. And then the 90s obviously were the mode of the SIMV. So if you think about the 90s, that's the SIMV time. Lots of dependent parameters came out like this, and that created the weaning protocols that we're going to talk about in a second. So the waveform looks like this. The breath is divided into three portions. The first portion is the controlled portion. So basically, you're going to get the breath no matter what. The second portion, if you want to take a breath, the machine will actually give you a pressure-supported breath, which is a tiny breath like this, just a little support. And then the third portion, it's very close now to the next breath here. So the third portion, if you take a breath here, the machine will give you a full machine breath, assisted breath, 500 tidal volume, right? But then reset the time, so you don't have breath taking. So that resolved the whole idea. That's why they call it synchronized, intermittent, mandatory ventilation. So this mode obviously was a revolution. It caused a lot. People would decrease the sedation, blah 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 blah, and the whole, every single ICU was an SIMV until it died in 2000. Not 2000, but the study that killed it came in 2000. But then people started continuing to use it for another 5-6 years after, and then nobody's using it in acute ICUs except some surgical ICUs, because sometimes they, So in 2000, that study is the same study that brought us SBT. So SBT, Dr. Tobin actually compared SBT versus pressure support weaning versus SIMV weaning. SIMV was introduced as a mode for weaning, and found that SBT is number one, pressure support was a close second, and SIMV was the worst. It actually, not only number three, it was the only mode of ventilation that had a significant number of patients, more than the others that had failure to wean completely. So people started to move towards SBT and left SIMV, and SIMV was dead. There was no need to use SIMV after that. If that's the only thing that came out, I wouldn't leave SIMV. I would have continued with SIMV. I mean, okay, one study. Where is the other confirmatory studies and all this? Nothing. But that actually mirrored the practice, mirrored the complaint that people were actually having against SIMV, because SIMV was actually really slow to wake up. So as I told you before, the dependent parameters, because there's the barrage of dependent parameters that came at the intensivist, there was a lot of, they had to like, organize it in a way, because I would look at the respiratory rate, you would look at something else, everybody would look at something else to wean the patient. So they had to come up with some weaning guidelines and parameters. So the whole weaning protocols came from this era. And I think it's because of the SIMV, right? So multiple ways that were developed. One of, so I'll tell you the last study, or the most famous study out of them, which basically they put three things against each other: physician-driven weaning versus pressure versus respiratory therapist-driven weaning versus protocol-driven weaning, right? And do you have any guess?
Physician's worse.
Yeah, the protocol-driven weaning was the best, followed by respiratory-driven weaning, and then the physician-driven weaning was the worst, because every few days you change the vent one time or something, right? So the protocol-driven weaning was the way to go, and the protocol was that every 6 hours you're gonna change the vent by one thing every 6 hours. So you have four changes a day, and the changes has to be small and gradual. So for example, if you get somebody that has 500 tidal volume, respiratory rate of 20, FiO2 of 100%, PEEP of 15, and pressure support of 20. That's like nice, good settings. The patient is sick. Now if the patient is, you want to wean the patient, the first thing you wean is the FiO2 gradually until you reach to 50%. Or actually at that time was 40%. And then the next step is to go down on the respiratory rate gradually to like literally 18, 16, blah, 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 every 6 hours, until you reach to 6. And by reaching to 6, that means you're giving only 6 for the patient, and the rest is the patient's effort. And then the next is to go down gradually on the pressure support until you reach to 10. And then the last thing is gradually go down on the PEEP until you reach to 5. And when you're 10/5, take the patient off the vent, put him on TPs. You guys know the TPs? Which is a blow-by, basically. It's not a vent, it just goes from the wall. So you get the tubing, it looks like vent tubing, and it just delivers oxygen like this, and the patient can suck in an endotracheal tube, whatever they want to breathe. So that, if you think about this will take about 4 days or so to wean this patient. Even though the patient could be ready to be extubated day 1. But going by the protocol, it takes a long time to wean the patient. And that's what killed the SIMV. That's actually what caused this problem in the study. Right? So that's why nobody uses SIMV in acute ICU, legitimately at least. It's the only place that some people use it is in the rehab places, because time is not an issue there. Just leave them there and let them wean very, very slowly. And it has less alarms than pressure support, so why not? Right? But to the defense of the surgical ICU people that they mentioned, some of them, not all of them, very few of them actually, that use SIMV in their ICUs, they're not using it this way. They're just using it because they're used to it, so they put the patient on it, but then every day they would do SBT. So it's kind of not that bad, right? And also, extubate the patient. But there's one thing that is wrong with that, even with that way of doing it, is that SIMV confuses the patient a little bit. There's a lot of different breaths. Sometimes I take a breath, I get a pressure support breath. Sometimes I want to take a breath, I get a volume controlled breath, and it's all over the place. So the patient requires a little bit more sedation than volume control. Okay? And that is it.